this is tab 6 for surgical anesthesia. I'm actually looking up the patient for surgery. Right now, we had just moved the patient in, and I have him hooked to a respiratory monitor and hooked to our pulse ox. So what the respiratory monitor does is it actually monitors the time in between breaths and has a little alarm if the patient isn't breathing. We can see the patient is breathing easily. Since we had just moved the patient in, I went ahead and changed his ISO to 2% based on him in the proper surgical plane of anesthesia. He is, his eyes are central and slightly dilated. He is nice and pink. He has no pedal response and no preapical reflex response on the medial canthus of the eye. His heart rate is 95 beats per minute and his oxygen saturation is 97. So he is in a good, safe position to go ahead and start hooking up the machine. We have his oxygen right now at 0.5, and again his ISO I said was at 2%. Our actual big machine does everything but the respiratory monitor, so I'll have to unhook this to hook up the big machine, and it'll also do the pulse ox on the big machine as well. So when you're setting up our big machine here, for our system, you have to actually hook this up before you turn it on, and this is for the blood pressure cuff. You want to make sure the cuff is about 40% the width of the lens, and you want to make sure that it is secure to the patient and that it is also within the marked level of the rest. So you want to make sure it's going to read appropriately. We throw a little bit of tape on the end because to make sure it doesn't come undone during surgery. You want to make sure you don't run the tape all the way around, or that could affect the actual reading. I'm going to go ahead and re-secure our patient here and turn on the machine. And the blood pressure cuff, the typical standard blood pressure during systolic is going to be 90 to 160, and that's when the heart's contracting. During diastolic, when it's expanding, it's going to be 50 to 90. And our mean arterial pressure while under anesthesia, we're going to look at it between 70 and 99. So, now that our machine is up, the next step that I'm going to go ahead and do is put in an esophageal lead. You have to make sure with our system that it's preset to a dog and a small dog. You can also take these little leads out and put them directly on the limbs. And this is going to read for the ECG also. But in our system, you can do this off of the geo lead, and it does all of that. So you want to go ahead and measure about to the elbow, from the chin to the elbow. We're going to go ahead and leave it, and we're going to go ahead and slide the lead down the esophagus. The patient is intubated with an endotracheal tube, so it should only go down the esophagus, and it should go pretty easily without any resistance. And so now that we have the lead in accurately, and I'll go ahead and move the camera when I'm done so you can see the machine and all the readings. It's going to show me my ECG, which actually shows me my P, Q, R, S, and T. The P is the atrium contracting, the Q, R, S is the ventricle contracting, and then the T is the ventricle depolarizing. So that is a good sinus rhythm right now. It also does the heart rate as well, which is 96, which is good for our patient. We want it to be about between 80 and 120. We're on the table. We're going to continue hooking our patient up. We're going to make sure he's hooked up to his IV fluids.
Okay, look at that. It's just like moving over there. Right. Do we hear anything? This tooth is like 2 seconds from abscess.
When I talked to Eric, and the instructions weren't on the estimate, the estimate's on the estimate like we're supposed to.
We're going to go ahead and turn off the portable pulse ox and hook up the one linked to the machine. The pulse ox you want between, it should be about 99 with a patient on pure oxygen, anywhere from 95 to 100. you're concerned about.
Ask the beta doctor, she never saw the dog.
I'm just adjusting the esophageal lead. It got moved a little bit when I was touching the tongue.
Okay, well, if I have to eat it, I will. I'd rather get good work this time down and work. Right?
I can't imagine if they would send it or, removing it from us.
Are they super easy?
No idea. I know absolutely nothing.
Well, maybe. Just see that gross stuff in there.
I'm going to go ahead and tape it in place because it's kind of finicky now that it's reading appropriately. I'm going to hook up our CO2 monitor. And I'm going to go ahead and set the machine to read the blood pressure. I'm going to go ahead and since we are just moving into the surgical suite, I'm going to note the time I'm getting these readings. What the heart rate is, which is 93. I'm going to go ahead and get a rectal temp. We have our blood pressure is reading right now, and it's the mean arterial pressure is 60, which is a little low. So I'm going to check with the doctors, and we'll potentially adjust his
That's okay.
IV fluids. But it's reading 89 over 32. The oxygen saturation is
So that
92, or the oxygen saturation is 97. Our carbon dioxide level is 32. Typically you want 35 to 44, so it is a little bit low on that as well. So we'll note that for the doctor. Like I said, the blood pressure is a little low, so we'll let the doctor know. The pulse is great. It's at 91, which we want between 80 and 120, and the pulse ox is 97. Right now we're on 2% ISO, 0.5 flow rate. So I'm going to go ahead and I'm going to notify the doctor about the blood pressure. We're going to go ahead and take his temperature and pre-scrub so the doctor can go ahead and start the procedure. All right, we are continuing to do the neuter on Pappy. I had checked with the doctor, and due to the blood pressure and the temp being a little bit low, we turned down his isoflurane to 1.5%, and we're also increased his fluids to 30 mils an hour. So we're going ahead and doing I'm recording his heart rate. His heart rate right now is 88. His temp is still a little on the low side. He is on a warming blanket. His temp is, right now, our machine reads it a little lower than it is. I do have a thermometer in, but the thermometer is reading about 94 when we just took it. The respirations right now are 23. His capillary refill time was less than 2. You want to do that by actually pressing on the gums and watching how quickly the pain returns. Right now, his eyes are still pointed forward. His pupils are slightly dilated. He's nice and pink, and so he seems to be at a good anesthetic plane right now for surgery. His blood pressure is improving. It is 97 over 40 with the mean arterial pressure at about 70, so it's still on the little lower side for the mean arterial pressure. Sorry, 97 over 40. His level is reading at 95. His carbon dioxide level is at 22. His ISO, again, we turned him down to 1.5. His oxygen flow rate, we're keeping at 0.5. And his fluids are up to 30 mils an hour. I'm going to go ahead and adjust the position of the pulse ox on the tongue. Sometimes if the pulse ox is reading a little low, it's because it's in the position or his tongue can dry out, so we'll go ahead and moisten the tongue. We're continuing to keep an eye on his blood pressure. The doctor aware that it's a little low and his temp. Otherwise, he seems to be doing well during anesthesia. Again, the respiratory rate is right in the normal, a little above normal. We want to see 8 to 20. He's at 23. His heart rate is in the normal range. So we'll go ahead and keep monitoring while he's under anesthesia. Alright, so Dr. Davidoff is starting to close. We're actually going to reduce the ISO down to 1%. We want to keep them as light as possible, so as they're starting to get to the end of the procedure, we're slowly going to be decreasing their planes of anesthesia. We also are rechecking his stats, and then we will, once she's completely done, we'll turn him to oxygen and let him wake up on oxygen. They're actually doing a narrow surgery where they're elongating the nostrils. I reposition him. We have warmies and a towel on him since his temp is a little bit low. His heart rate is 101. We have him back on 1.5 right now, and as she's wrapping up, I'm actually turning him down to 1. Again, his temp is a little low. It's about 93 right now. His respiratory rate is 29. His capillary refill time, I'm not going to check right now while she's by his mouth. His blood pressure is better. The mean arterial pressure is 75, which is right in that normal range of the 70 to 90. It's actually 107 over 46. The diastolic's still a little low. His O2 saturation level is 95%, which is at the low end of normal. His CO2 level is low, it's 28. And his ISO rate right now is at 1%. His oxygen flow rate is at 0.5, and his fluids is still at 30 mils. We adjusted for the low pressure throughout the procedure by increasing the fluids and turning down the ISO. I was continuing to check his anesthetic planes by his reflexes, eye position, coloration, his stats. Again, the heart rate we want between 80 and 120 while under anesthesia. The CO2 level, typically it'll read 35 to 45 on these, so our CO2 has been a little low throughout the procedure, but I made the doctor aware. Our pulse ox saturation, the actual pulse ox measures the amount of hemoglobin attached to the oxygen, so it gives us the oxygen level in the blood, and that has been good. It's at the low end of normal. It's normally about 95 to 99. You want it close to 99 while they're under anesthesia breathing pure oxygen. We've already talked about his blood pressure. Oh, the CO2, it actually hooks to the end of this corrugated tube, and it's going to measure the amount of CO2 they breathe out, and it's also showing his breaths on here. The line up is actually the inhalation. The top of where it plateaus is where the CO2 level is, and the line down is him exhaling. So I'm going to go ahead and scoot it closer so you can see the machine. And right there is the ECG lead. You can actually see the pulses, the quality of the pulses. You can see the P, Q, R, S, and T waves there. You can see his pulse, and that's through the esophageal lead. The next line, the blue, is the CO2. You can see his breath. And again, it's a little low at the 28. The doctor knows about that. The purple is the 96 is the pulse ox. The next line down is the blood pressure. It takes it every 2 minutes, so we have 30 seconds for it to readjust on that. The temp has never really worked on this particular machine, so I've been taking rectal temps, and I will recheck our rectal temp, but we've been around 95 to 96. So we added more warmies, and we'll go ahead and get him in a hot water circulating blanket in his recovery cage and keep a close eye on his temperature. And so that is the machine. She is wrapping up, so I'm going to actually go ahead and turn him on to straight oxygen. I'm going to retake his temp here. And sometimes you can get a little artificial temps if they are in poop or things like that, but he is a small patient, so we definitely are going to keep a close eye on his temperature. Great. We're going to go ahead and monitor when we turn the anesthesia off, the exact time. I'm done. And the doctor is done, so we're going to go ahead and keep him on his anesthesia, especially since a pug. We want to go ahead and keep him, sternal the tube in as long as possible and keep him on anesthesia and oxygen for a while we're warming him up and he's waking up. So that's monitoring a patient under anesthesia. All right. This is Samantha, and I am, our patient is extubated. It did take me a little while to fully extubate because when we're a pug, we like to keep the tube in as long as possible. And our patient got pretty cold despite the fact that he was on a warmy circulating blanket and we had a nice towel. We had brought in hot water bottles. Once we had flipped him with the V tray and on the circulating blanket, there's no additional place for hot water bottles, so the circulating blanket should be sufficient. We did wrap his fluids and kept it in on a hot water bottle, and I was warming him with a hair dryer because towards the end of surgery our temp was down to 91. We were maintaining through most of the surgery around 94 degrees, but we were dropping towards the end of surgery. Sometimes it can be the length of the anesthesia procedure, but this was a pretty quick one overall once we got him into the surgery suite. It can be the size of the patient, it can be if the patient's damp, and while they're under anesthesia they don't metabolize the same way, they can't shiver, so keeping them warm is one of the things we really want to work with. He was awake and for a good deal of the recovery monitoring, but not extubated, just enjoying his warmies and being able to breathe, which is something that you'll notice with a pug. So I will go over our sheet and then I'll go over how to clean up. This is a sheet that I had just got off of online. We don't use this particular type of sheet here. We had the initial section is actually from us in our prep area where we use just a regular pulse ox and the heart rate. I had documented the heart rate and the breaths, and you give a breath every 5 minutes, and so I had checked that when I was documenting the breaths. I don't think I actually got to show you on camera, but you want to squeeze the bag, and you want to only squeeze to about the 10 to 15 centimeters of pressure here. So when we got into the surgery, I have the documented about 145, and then we had taken it every 5 minutes. I continued down here doing the temps. He is completely extubated at this point. He was biting on his tube. His temp's still pretty low, so we're still monitoring his temps every 5 minutes, but he's awake, he's shaking, he's moving around, blinking, obviously too awake to have a tube in. So we're just going to continue to monitor his temperature. So I have on here this anesthesia start time, end time, when we extubated. I have our checks throughout surgery. And again, I have documented that during surgery our blood pressure got low. We actually, due to correcting the fluids in the anesthesia, got our blood pressure back to normal. And I also documented everything we knocked out with. So I'll go ahead and submit this with the video. And so now we're going to go ahead and clean up. You want to go ahead and use a neutral type cleaner on these. We use the same spray for our table as we do for our tubes lines here. For the actual ends of the probe and for our esophageal lead, we'll actually use mild soap, making sure we don't get the end of the lead wet. For these type of things, you can use chlorhexidine solution as well. We do Stoker endotracheal tubes and chlorhexidine, and it's a safe cleaner for these type of things. You want to make sure you're cleaning on the ends of each of these tubes carefully. And we're going to go ahead and roll these up. And I'm going to set it aside. I have Ziploc bags that we actually put all these tubes in. We're also going to go ahead and clean the pulse ox end. They got a good amount of blood actually down in here, so you want to make sure that you're cleaning every little section and see all the blood we're getting out of there. Especially taking care to make sure you're cleaning the part that is against the tongue. We're going to go ahead and dry each of these instruments. And unplug them. And we're going to go ahead and make sure that we clean the line as well. For this part, we can go ahead and use our cleaner. We're going to go ahead and spray the rag directly. We don't want to spray directly into the cleaner. And we're going to clean the entire line. And then we're going to roll these up and put these aside, and I'm going to put them in Ziploc bags. We take the probe end that connects to the corrugated tubing, which is actually for the CO2, the capnograph or the CO2 monitor, and we're going to go ahead and wipe this line as well. Making sure there's no blood or anything on it. This is where the esophageal lead connects to. This we're going to unplug as well. It says quite a few cords. We're going to make sure the box didn't get any blood on it, doesn't have any liquids on it. Again, you don't want to get any of these actually wet or submerged in any reason. We're going to make sure all the cords are clean. These cords aren't kept on the table. They're actually hanging off the table, so you shouldn't really have any blood or anything on these unless you're doing some kind of sometimes we'll do like foreign body surgeries or other things where they may have maybe more messy, or dentals, or maybe vomit during the surgery where they would get fluids at the top. But you always want to make sure you're wiping off all of the cords. This was the probe for the respiratory monitor, which we didn't use during surgery, but I demonstrated prior. And make sure the probe ends of all of these are clean as well. This one, again, we didn't use during surgery, but I demonstrated prior, is our backup pulse ox. And now we're going to go ahead, and the machine is turned off. We're going to disconnect the blood pressure cuff and remove the end. We're going to clean this tubing as well. And then we're going to spray down and wipe down our table. It's important to always have a clean workspace and clean your area once you're done with surgery. And once your patient is completely extubated. We have all of the surgical pack tools soaking. And so now that we are done cleaning our big machine, we're going to go ahead and spray down the table, put away our warming pad, and that is demonstrating cleaning up your surgical area. Our big machine is turned off, and now that this is wiped down, including the cords, there is no blood or anything on the particular warming. So a quick wipe down here is sufficient. We're going to clean off the table. And that is cleaning up your surgical supplies. I have each. We keep all of our tools in the crate with individually Ziploc. So I'll go ahead and put these away where they go. And that it concludes task 6, demonstrating monitoring while under surgery.